Good morning, everyone. Yeah. I always have to adjust the mic, of course, short. It always comes about after tall speakers. It's not fun coming just before lunch. Everyone wants to jump to lunch. So I will talk about imaging, and I'm happy that all my colleagues were very enthusiastic about imaging who talked before. So that gave me a very good start and introduction. So I will try to tell you what you need to know. I'll try to explain and try to answer all the things that you have in mind. My background, I'm a radiologist, and I'm also nuclear medicine physician at the same time. So nothing to disclose. I'm not going to talk a lot about this. You guys know neuroendocrine tumor is rare. It originates from the neuroendocrine cells. They are in multiple organs. They have some common features, but they have features from the organ they come from at the same time. Okay, rare tumors. All right, let's talk about imaging, because this is really what I'm here for. And because I'm an imager or a radiologist, so it's going to be tons of photos, I promise. So, because we love images, and this is fun to be a radiologist. I will take you, from the historical, chronologically, from the back time. And I will show you a curve showing you the incidence of neuroendocrine tumor and how it increased with time. And I believe, like a lot of people do, that the incidence of neuroendocrine tumor did not increase because it's not like lung cancer. It's lung cancer increased because of smoking, that we have predisposing factors that we know that increase lung cancer, right? We have a lot of cancers that have a lot of predisposing factors we know about. Neuroendocrine tumor is not like that. So we know that it's not the incidence increased. It's more of we have better tools to find it, right? And I believe that imaging is the major reason, the advances in imaging is the major reason why there's a steep increase in the incidence of neuroendocrine tumor. I hope that I can convince you today that really we are one of the major, I'm not going to say we are the only, because we are not the only, but we are one of the major reasons why there has been steep increase in the incidence of neuroendocrine tumor and in the earlier detection of neuroendocrine tumor as well. So if you go back maybe like 20, 30 years ago, the CT scanners were slower, right? Because this was the technology. We had what we used to call the step and shoot CT scanners. And I did work on that because I am from Egypt. I'm an American Egyptian, okay? So I was a radiologist in Egypt before coming here. So I did work on a step and shoot. And this is an opportunity not all radiologists in this country do. What does a step and shoot means? It's exactly like it says. The CT scanner was so slow. And then what happens, if you see a CT scanner, I'm sure all of you already been in a CT scanner. You have the table or the bed you are lying on, and the CT is like a round, a circle that you get through, right? So what happens is that the table move, and then take a picture, and then the table move, and oops, take a picture, right? This is why it's called step and shoot, step and shoot, step and shoot. Can you imagine? This was the original way we used to take the CT images. So to do a CT of the abdomen and pelvis, it would take us like 30 minutes, right? Or when it got a little bit faster, it became 15 minutes, okay? So for that reason, catching the contrast in the early phase was impossible. It was like for us, this is like something we can dream only of. It's never gonna happen. We always get the CT in these, like you see these bottom images here. This is venous phase, I label them. And you will have a lot of arrows because I want you to see what I'm talking about. So venous phase, delayed phase, okay? You see a liver. Beautiful, one slide in the liver, nice, beautiful, and the linear white things are just the vascularity, nothing. There's no lesions I can see, I promise. Ugh. Maybe I should go back like this. It's either too loud or too, oh, okay, all right. The issue of I'm talking about the well-differentiated low-grade neuroendocrine tumor. The issue with them, they are hypervascular. What does that mean? They enhance very early in the arterial phase, and then they wash out, and they blend with the parenchyma, okay? So nothing here. So we have to catch the contrast early on in the arterial phase. Now I'm showing you an arterial phase CT of the same slide. And you can see now two lesions that we were not able to see when we had the older scanners that are slow, right? Why am I showing you this? Because in the early 90s, when we started having what we call the spiral scanner or the helical CT scanners, that was revolutionary for us as radiologists, because all of a sudden we managed to do what we call now the triple phase CT or the multi-phase CT, right? We can now have an arterial phase, venous phase, and delayed phase, and we can see lesions that only are enhancing, are seen in the arterial phase and blend in the venous and the delayed phase, right? And at this point, we started to see metastatic neuroendocrine tumors that we were not able to see before. So patients with metastatic neuroendocrine tumor would come to us, we do a CT, and the CT is negative. We could not see anything. Now we can see them, right? This is the curve I was talking to you about. This is showing you the incidence of neuroendocrine tumor, which is the yellow or orange curve from 1973 all the way till 2012. It's a very famous curve for us, right? And then I will highlight to you at 1992. You start seeing a slow increase in the incidence, okay? Now let's talk about somatostatin receptors. Neuroendocrine cells have express five types of somatostatin receptors. We are interested in somatostatin receptor 2, and in the beginning 5 as well, right? Okay, I'm going to skip this. 1994, which is 2 years after the CT, helical CT came to the world, we developed what we now, the Octriscan. You guys know Octriscan, Indium-111 Octriscan, which what I do, because I'm a nuclear radiologist, right? This was really revolutionary. Why? Because it's a targeted imaging tracer. It actually go and bind to the somatostatin receptors on the cell surface of the neuroendocrine tumor cell. Can you imagine? We in nuclear medicine, all of our departments are called nuclear medicine and molecular imaging. Why are we called like that? Because we can see process that happens on the molecular level. So like this was happening here. Something that goes and binds to a receptor on a cell surface. Can you imagine? And I can see that on an image. That is cool. That's very, very cool, I think. So I inject the radiopharmaceutical, right? And then what happens? This somatostatin analog goes and binds to the receptors. So what happens is that this is a somatostatin analog, like what you, like the SSA that you guys take as a medicine. But what we did is that we attach it to a radioactive nuclide. This radioactive nuclide, my cameras can see. So basically something goes and binds to a receptor, but I cannot see it. Then I attach it to something that I can see. So I can see both of them. Cool, right? Then the Octriscan came in play in 1994. For us, that was revolutionary because all of a sudden we have a specific radiopharmaceutical or radiotracer that can actually specifically show me neuroendocrine tumors, right? And here is an anterior and posterior whole body images of a patient with metastatic neuroendocrine tumor. A lot of studies have been done showing higher sensitivity and specificity, increased detectability. So now we have two things. We have triple phase and we have Octriscan. Now look at the curve. And I have the purple arrow showing you 1994 on the curve. And the steep increase in the incidence starts from there. And this is where I think the combined effect of the triple phase CT and the Octriscan. Okay? Now, imaging, the role of imaging in general. Imaging is so important because it has an impact on all the stages of disease. It's important to detect the disease. It's important to stage the disease. It's important like when we start doing treatment, it's important for treatment response assessment. We need to see how is this treatment going on. Are you improving or not? Do we need to continue doing this treatment or do we need to think about shifting to a different treatment? So tailoring the treatment and the management is important, right? And following up afterward. So imaging is crucial along. Right now, anatomic and molecular are both important. There is always a hybrid between anatomic and molecular. We either alternate them or do them together, but both of them are so important. Okay. I will give you hints about each one, the anatomic, but then I will focus more on the molecular because this is what I really do. Anatomic, CT, have very high spatial resolution. This is a big advantage. And with the CT, the multi-phase, of course, So if somebody, if you have a well-differentiated low-grade CT and your medical oncologist tell you get a delayed only or a single-phase CT, do not do it, I'm sorry. It's useless. It's useless. I showed you. It does not detect anything. It will miss your tumor. It does not help. You need the triple phase. And Dr. Anthony, in our institution, he requests multi-phase CT for our neuroendocrine tumor patients. For metastatic colorectal cancer, for other tumors, it's fine to do delayed phase only because the tumor can show up in delayed phase only. But for well-differentiated, low-grade neuroendocrine tumor, it doesn't help. We will underestimate and miss cancer. So talk to your doctor about that. Just you have to discuss it. Say, oh, I heard or I read about this. Multi-phase is very important. So this is so important. So low-grade tumor, neuroendocrine tumor, high-grade neuroendocrine tumor looks a little bit different on CT. The low-grade well-differentiated tumor would be like the metastatic disease will tend to be smaller, like smoother, more homogeneous. I will show you an example. The higher grade will be larger metastatic, more heterogeneous, necrotic, and actually they will be, how I showed you in the lower grade, they are more arterially enhancing and then they blend in. The higher grade, they are gonna be persistently enhancing through all the phases. So this is an example of a 49-year-old female patient with stage 4 grade 1 well-differentiated pancreatic neuroendocrine tumor. And I will show you the metastatic disease in the liver because the liver has a big surface and you will see the parenchyma, so it's going to be easier for you to see the metastasis and the parenchyma and see the difference, right? And I have arrows. See the tumor, the metastatic lesions on the arterial phase, right? And how they blend in the venous phase, and you don't still see them in the delayed, or you might see a tinge of, lower, like darker in the delayed phase. Now, this is a higher grade, well-differentiated. So this is a 64-year-old female, stage 4, grade 3, well-differentiated, but it's a grade 3. She is a well-differentiated, but grade 3 pancreatic neuroendocrine tumor. And now we see the metastatic disease larger, more heterogeneous. See, I have some arrows. And of course, the yellow arrow is actually the primary site, which is a large infiltrating pancreatic tail that was infiltrating through the spleen and the kidney. But see, I don't need to put arrows on the liver mets because I think, guys, you can see it, right? They are studded in the whole liver in the first arterial phase. Do you guys see it? Right? But you can still see it in the venous and because this is higher grade. It's not grade 1. This is grade 3, well differentiated. Right? MR has more soft tissue differentiations, better for the soft tissue, right? And provides more advantage with the soft tissue lesions. And also we have a hepatocyte-specific contrast, which is the EUVIST. When we have smaller metastatic lesions that are indeterminate, we always do MRI to characterize are these metastatic disease or not. So this is why we do MRI. And we have diffusion-weighted imaging, we have elastography, we have other advanced techniques for that. This is an example for an MRI for smaller lesions, and what we do is again, there's diffusion, arterial venous phase, and we do 10 to 15 minutes delayed phase to look for washout to confirm this is a metastatic disease. So but we do the MRI usually for questionable indeterminate metastatic liver lesions. So we do the liver-directed or liver protocol MRI for these cases. I will now focus on the dotatate, which is what I love. We talked about OxyScan, which was amazing and revolutionary, and we were happy about it for, I would say, 2 decades or like 2.5 decades. Then dotatate came in play, and it got FDA approval in 2016, right? And it was amazing. This is the same patient, right? Well-differentiated, low-grade neuroendocrine tumor, and I have an OxyScan and a dotatate side by side, and these scans were done 2 months apart. Right? And I have arrows showing to you the lesions on dotatate that I cannot see on the OxyScan myself. And you can see yourself. Lesions that you can detect in dotatate, you cannot see retrospectively on OxyScan. And the reason, well, both of them are somatostatin analogs, so they bind to the somatostatin receptors, right? So the problem is not the biological part, it's not the somatostatin receptor target. The problem, the issue is the SPECT versus PET, our modality, which is both my modality. So I'm not competing with anybody. So I'm not telling you that the body imagers cannot find it, but the nuclear medicine is finding it. I'm not, right? Both are mine. I read the SPECT, I read the PET, okay? It's me, I'm fighting for myself, okay? So there's no conflicts here, promise. But SPECT versus PET by physics. I'm not going to bore you with the physics behind it. PET as a modality is better by physics than SPECT. This is why the image is much better. The detectability is higher. The quality is better. The sensitivity, there are literature and a lot of research proving that dotatate PET is better than Octreoscan SPECT. Okay? So this is the image quality, detectability, and sensitivity. I already proved that. Now, let's go. This is the PET scanner. This is the SPECT scanner. All right? The SPECT scanner is 2 cameras. 2, okay? The PET is a full ring of detectors, right? And this is the, technically, I don't want to go into this. Like, there's a lot of technical aspects that differentiate both, including that in PET we have quantification. I can do SUVs, which is a quantity. I can tell you the SUV of this lesion is 30. In SPECT, I cannot do that, all right? Okay, somebody can tell you, okay, but what about the radiation? Maybe PET give me more radiation than SPECT. Actually not, right? Actually, PET, the dotatate, give 20% the radiation that Octreoscan give. Why? Because the half-life is much shorter. Dotatate, the gallium-68 is 68 minutes half-life. So it gets out, decays, gets out of your body quicker, much quicker. While Octreoscan is 72 hours, it's 72 hours, like it's around 3 days. So it hangs in your body for a longer time. So, and this number is my radiation safety officer. I asked him to calculate based on the standard dose that we give to the patient, dotatate versus Octreoscan, and this is the number he gave me. So radiation-wise, dotatate is still better. Logistic-wise, okay? Logistically, this is something everybody cares about. If I'm going to a doctor, I always care about how long am I gonna stay and wait in the waiting room, right? So Octreoscan, let's start with Octreoscan. You come, we inject the radiopharmaceutical, right? You wait, sometimes some places do a 4 hours imaging, some places don't. And then you come, you have to come 24 hours later to do the 24-hour imaging. This is a must. 24-hour imaging is a must, right? This is standard. And then, come on. Sometimes we do 48-hour imaging, so plus or minus 48-hour imaging, okay? So 2 plus or minus 3 days is the Octreoscan, okay? Dotatate. You inject. It's like FDG. You wait for an hour. The imaging is 30 minutes, and you leave. So let's say around 2 hours. You are in our suite around 2 hours. So logistically, dotatate is amazing versus Octreoscan. So it's a win-win situation, right? So there is nothing that Octreoscan beats dotatate in, honestly. So if you ask me, is there any reason or any situation I would prefer doing Octreoscan for a patient? No, there is nothing. And for years now, we haven't done a single Octreoscan for any of our patients. We only do dotatate. We stopped doing Octreoscan, period. And we do a lot of dotatate in our institutions. I think we are one of the highest number of dotatate in the country because we have Dr. Anthony, and he is one of the experts, and we get a lot of referrals. So we have a lot of patients that comes through our institution. In the first year, to be honest, anybody, when we get outside, doctor referring Octreoscan, we would call the doctor and say, hey, we have dotatate now. And dotatate is better, and I explain to him this. Please change the referral, the order to dotatate. And maybe 1 or 2 cases where the insurance of the patient refused to pay for dotatate, and we were forced to do Octreoscan in the first year, 2016. But then from after that, we were able to do dotatate for everyone. For years, I haven't done a single Octreoscan. Okay, now let's talk about dotatate. I'm gonna talk to you about when do we do dotatate? What are the indications? I'm gonna go based on this report that came out in 2018. Many representative of all these associations, like the Society of Nuclear Medicine Molecular Imaging, the American College of Radiology, all these, the ASCO, American Society of Clinical Oncology, NANETS, neuroendocrine, my God, the North American Neuroendocrine Tumor Society. All these are all the big people interested in neuroendocrine tumor, in oncology, in radiology, in cancer. All these got like representative from all these groups got together, sat down, and discussed and came out with appropriate use criteria for dotatate. Good, we will believe them. So I will go with this. One by one. The first one, they came with initial staging after histologic diagnosis of neuroendocrine tumors, which means what? Baseline. Doesn't that mean baseline? Cool. And I will go with examples, of course, because I told you, it will be tons of imaging. I'm a radiologist. So this is a patient here. The left side one, the big white thing, is a MEP image, which is a maximum intensity projection, which means, you know, in PET, we have a rotating 3D image. Now, this is just a static image of it to show you an overall look of the whole body, to give you an overall idea of what's going on. And this is a patient with stage 1 pancreatic neuroendocrine tumor. The top image is a contrast-enhanced image, and the lower image is a fused image. What is a fused image? Because it's a PET CT. Our PET CT camera is two cameras, actually. A PET camera and a CT camera, and we stuck them together. If you look from outside, when you get into the PET CT camera, you think it's one. It's actually two. And we put an outside body. So from outside, you think it's one thing, but actually when you open it, it's two cameras. It's a PET and a CT. And what happens is they are not done together. It's not simultaneous. They are sequential. You get a CT and then you get a PET, right? But it's in the same setting. You're sleeping, you are laying down in the table. We get a CT and then we get a PET. So this is the best optimum situation we can do with two imaging that cannot be done in the same time. So what's the best situation if I'm doing two modalities? The best situation is the PET-MR, for example. What's the PET-MR? In the PET-MR machines, they are done together simultaneously. We acquire the PET and MR images at the same time. Why is it optimum? Because there's no motion happening between them, right? But PET-CT, we cannot do that. So what's the next best is, at least you are laying down in the same time, you do the CT and then we do the PET. There will be a little bit of motion because we are human, we move, and there are involuntary motion happening, like the respiratory motion, right? The bowel move, this is you cannot control your bowel moving. So there will be some motion happening, but this is the best we can do, given that I cannot do them at the same time, right? So this is the PET-CT. So we get two sets of images. We get CT images, we get PET images. And PET MRI is the same thing. We get two sets of images, PET images and MRI images. So I look at the PET alone, CT alone, and I look at a fused images, which is the bottom image, which is the PET, and then we color the CT, and then we color the PET because we are the cool image, of course, right? And then no, it's not true, of course. It's not because it's the functional image. And then we overlay it, the software does, overlay it on top of the CT image. This is why you see a colored image on top of a gray or black and white image, right? So the black and white is the CT image, which is the base, and then the colored image is the PET image, right? And this is what's gonna happen from now on. I just wanted to explain what you're seeing so you know what you're looking at. So this is a stage 1, a pancreatic cancer. So the top table there on the right top is the staging based on the AJCC, the 8th edition, right? Just for your information. So this is just a small cancer, no lymph nodes, because you see the whole body showing no lymph nodes, no distal metastasis. Stage 1. Now this is a stage 2. Why a stage 2? Because we have a larger tumor that is involving the duodenum, right? But there's still no lymph nodes and no distal metastasis, so it's stage 2, pancreatic NET. Come on. This is a stage 3. Why? Because there is a small pancreatic head neuroendocrine tumor, and you see the green arrow there? There is a small lymph node, regional lymph node. So this became, although the tumor is small, but there is a lymph node, so it became a stage 3, right? And okay, let me go back a little bit. The important thing to show here is that the lymph node is small. The advantage of PET is CT has a size criteria to call a lymph node metastatic. If the lymph node is too small to be called, it's going to be negative by CT. But PET can call a small lymph node metastatic based on the activity, right? So we can upstage the patient based on the activity, right? This is a pancreatic tail neuroendocrine tumor, right? But there is liver mets. So this is stage 4. And this is another stage 4 because of the liver mets as well. Okay, let's go to the next indication. I just don't want to take a lot of your time because I know you guys are most probably hungry and want to go to lunch. Like I told you, this is the disadvantage of speaking just before lunch. And I can talk a lot forever, so I can take long time. I know that. So, localizing primary tumor in patients with no metastatic, so unknown primary. And this is an indication we get a lot. A lot of time, or I would say 99% of the time, it's a small bowel primary. Because small bowel primary are usually small. They're small in small bowel. Cool, right? And they are so difficult to find. They do follow through. They do, enterography. They still cannot find it. It's very, very tough to find. But the advantage of our molecular imaging, dotatate, we find it easily. Every time they send me this case, I can find the primary site. I will show you some examples. This is a case here. I don't know, can I aim with this? Is there oh yeah. Oh, but I can, but I don't know which one should I aim. Yeah, I can. But I would aim in this side once and it's just, well, I have arrows anyway. So, see how there's stage 4, distant metastasis. It's like a Christmas tree, right? A lot of disease everywhere, unfortunately. But they could not find the primary site. Okay, somebody can ask me, why is it important to find the primary site when there is that much disease in this patient? The importance is that in small bowel, eventually this will grow enough to obstruct, right? So it needs to get out. And it's better for a surgeon to work on a clean area than on an obstruction. And ascites and obstruction, and it's bad to work on an obstruction. This is a question I asked myself to my surgeon, my colleagues, and they said, no, it's better for me to find it for me when the abdomen is that clean and clear, and when I can get in quiet abdomen and get it out, than to wait. Then this is an obstructed abdomen, and it's very messy, and look for the obstruction. So it's better for me to find it now and take it out. Right? Because eventually it will obstruct. It will keep growing till it obstructs. All right, so this is, you see, the arrow is showing you the terminal ileum primary, and the CT is not showing anything. There's no mass. It's just focal activity in the terminal ileum. And when you look at the CT, retrospectively, you still don't see the lesion. It's just the activity. I have a lot of examples. And you will notice that the focal activity is not the hottest in the whole scan. It is not at all. Right? It's subtle focal activity. Again, down in the left side, small bowel primary. You see it in orange. This is it. It's not the hottest at all. This is the site of the primary. The next one. Come on. See here, terminal ileum primary. Okay, look at this one, the one that is a long cut in the fused image of the whole, showing the head and the whole body. Do you see that one? Now look at the blue and look at the yellow arrow. See how the blue is the mesenteric mass, and the yellow is the primary site. See how the mesenteric mass is much bigger and hotter, while the primary is very faint, right? So actually the primary small bowel is usually not the hottest, not the biggest in the whole body. It's very small, but this is the primary site. Can you imagine this tiny little thing is causing all this drama? Can you believe that? This is the reality of the small bowel, the midgut, right? So there's tons, I have tons of them, because I'm telling you, this is one of the common things that comes. All right, the next one. I'm not gonna go with all the indications. I just picked some of them to show you some. Evaluation of patients coming with biochemical evidence of disease, some symptomatic, and they do a lot of workup, they tried a lot of empiric treatment, and then they're now thinking of, so it's not the first thing that they think, because I got these questions in one of the presentation I did. Is this the first thing you think? No, it's not. It's not the first thing you think of. It's actually, usually the physician would do empiric treatments, try different things, and then usually later on at the course, they would think, what about neuroendocrine tumor? Can this patient have neuroendocrine tumor? Then they think of dotatate. Let's do dotatate and see, is this neuroendocrine tumor? And I'm going to give you a couple of examples, one negative and one positive. So one proof it is, one proof that it is not. Because dotatate is valuable in both scenarios, to exclude and include, right? To prove it is neuroendocrine tumor, or to say no, it is not neuroendocrine. Okay, I have to be precise. It is not well differentiated, low-grade neuroendocrine tumor, right? Because high-grade, poorly differentiated neuroendocrine carcinoma is not going to be dotatate avid, and I will show you why. All right. This patient had, you see, chronic diarrhea, flushing, facial flushing, even elevated chromogranin, which I'm not going to talk again about chromogranin because apparently everyone already told you how useless it is, right? And actually, he had appendicular orifice mass on colonoscopy. And now they're thinking, can this be a neuroendocrine, appendiceal neuroendocrine tumor? So they did a DOTA Tate. And actually, the DOTA Tate here, you see the yellow arrow? It totally, so the white background image is the MEP again, negative. And the fused image with the yellow arrow showing you that it's not picking up any DOTA Tate. So this is not a neuroendocrine tumor. So this is a case where we said, this is not a neuroendocrine tumor. Find another reason for the patient's symptoms, right? This is another case, 58-year-old male, had symptoms, received multiple, like I said, multiple empiric treatment, no improvement. And these are the lab work suggested they thought carcinoid. And I'm showing you the bottom image is an arterial phase contrast CT. And the proof that this is an arterial phase, let me show you. Okay, sorry. Here, okay, you see this? This is the aorta. Okay, do you guys see it? Let me show the other group. This guy, you see that? Do you see it? Okay, this is the aorta. This is the aorta. See how white it is? This proves that this is an arterial phase CT. I'm proving to you that this is an arterial phase CT. There is nothing in the pancreas. Do you see? But look at the top image. A tiny little pancreatic primary, only DOTA Tate saw it. Even the arterial phase CT could not see it because every modality has its limitation. And sometimes the limitation is the size. It's too small for the arterial phase CT to pick. But the DOTA Tate picked up, okay? Right. This is another case also, came to the 53-year-old, a young female, came to the ED with abdominal pain, nausea, diarrhea, came for further, again, chromogranin, serotonin, and blah, 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 whatever. She came, look at the DOTA Tate, but here, in the arterial phase CT, I can see the arterial enhancing lesion of the pancreatic head. Do you see it? I have an arrow on it, so you can see what I'm talking about. Okay, the next indication is monitoring a neuroendocrine tumor or metastasis that we only see. This makes a lot of sense. A lesion you see only on DOTA Tate, you have to follow up with DOTA Tate. No? You only see it in this modality, you have to follow it up with this modality, correct? Nothing else can see it. I have an example. This patient, and these scans are from 2020, 2021, 2023, 2022. And I looked at CT, MRI, cross-section. I looked carefully. I could not find any nodule in that region to really locate these two foci. It was puzzling. And they look, stable as you see here. Do you see the two blue arrows? These two intensely SSA avid foci. They are there, and they are fixed, and they cannot be an artifact. They are always there, along 3 years. But they are stable. There's nothing changing in them. And my CT, the contrast CT, because I always correlate with Breyer's, nothing changing. They look the same. I cannot find nodules in there. I cannot find lesions on the CT. Nobody can see lesions there. So we have to keep following them up with DOTA Tate because it's the only modality that can see these lesions, so we have to follow them up with the DOTA Tate, right? And this is, like, if you see the MEP image, this is the only disease in this patient. The patient is clean otherwise, nothing else in that patient. So very, very small volume disease. All right. And these are, this is a very nice patient. She has, I remember this patient has a MEN syndrome and had multiple pancreatic lesions. And all I wanted to show you here that these three images, I can count at least 6 or 7 pancreatic lesions, at least. When I went to the arterial phase contrast CT and I tried hard, and at most I can count 2 or 3 lesions in the CT, in the contrast CT, in the triple phase contrast CT. So triple phase contrast CT underestimate the tumor burden when you compare it to DOTA Tate in this patient. All right. Guiding patient management. This was a unique case. It happened early on when we started DOTA Tate. This patient had metastatic neuroendocrine tumor, as we see from all the images. But what I want to focus on is the rib lesion, the first rib lesion, that I have a yellow circle on and a yellow arrow on. We mentioned that lesion. Then Dr. Anthony asked the patient, and the patient said, this area, sorry, hurt, right? It hurts, and they had examination, it's tender, and the decision was made to do palliative radiation, just to ease the pain. Like I said, it's how you feel is what's the most important, right? Then they went to Dr. McGarry, our radiation medicine doctor, and they were planning for the radiation, and of course they do CT for the planning. Right now we have a new scanner, and actually we can do planning with PET right now in our institution, but back then it was CT. This was 2016 or 2017, this case. And then he did the CT, and as you see in the CT where I put the circle there is nothing at all in the rib. The rib looks clean, nothing. It's just the dotatate that was hot. And he couldn't see anything in his CT with planning, so he came to me in the reading room when I was reading, and he said, this patient, he's on my table, I should be doing radiation to him, I don't see anything. Show me what you're talking about. So I had to pull the patient and show him exactly where I see the focal activity for him to be able to go back and be able to do the radiation. So this show you how like the teamwork, the multi-D, like the teamwork, and how we can guide the radiation, we can guide the management of the patient. It's very important to have teamwork. Okay, this is what I was talking about earlier. And this is what's unique in this, because neuroendocrine tumor, it's one of the, this is how I think of it, it's one of the high-class tumor, right? It's not like colorectal cancer. It's more like a thyroid cancer, because it's a neuroendocrine, like it's a smart tumor, okay? What do I mean? When we talk about a grade 1 and 2, the low grade, well-differentiated neuroendocrine tumor, they express the receptors. They still retain the features of the cell of origin, okay? So actually, they are not like the common tumors. They're not interested in the common radiopharmaceuticals, which is the FDG. Our common radiopharmaceutical is the FDG. FDG is the radiotracer that we use for all other kinds of cancer. We do it for lung cancer, for colorectal cancer, you name it. For pancreatic adenocarcinoma, gastric, we do it for all other cancers, okay? So, but you have to have, so before the dotatate come and play or the oxyoscan, FDG negative. FDG would miss I forgot to tell you that, not only the CT, even FDG was negative for neuroendocrine tumor. It was one of our pitfalls. One of our weaknesses in FDG is that carcinoid. We could not see carcinoid. It's negative, right? Why? Because it's sophisticated. It's a sophisticated cancer. It needs somebody sophisticated to be able to see it, somebody to bind to the receptors, all right, to see it. So the grade 1 and grade 2 well-differentiated cancer need a dotatate, right? It will be hot. The FDG, not hot, especially grade 1. So when we are in grade 1, very well-differentiated, very high class, needs very targeted radiopharmaceutical, not interested in the FDG. When you go to the poorly differentiated neuroendocrine carcinoma, which is lost all the characteristics of the cell of origin, then it's not sophisticated anymore. It's more of the common. So it's FDG avid and not dotatate avid, right? This is why I say I have to be precise when I say this is not neuroendocrine. It can be neuroendocrine carcinoma, poorly differentiated neuroendocrine carcinoma, high grade, but it cannot be low grade neuroendocrine tumor. And then in the middle, it's in the middle. The grade 2 neuroendocrine tumor, uptake both of them. And this is an example. These are 3 different examples and in each box, it's the same patient, right? So the grade 1, the G1, dotatate and FDG of the same patient. And these are done within a month or 2 at most, the scans, right? Grade 1, see how metastatic disease, intensely dotatate avid, non-FDG avid, right? And then the bottom here is grade 2, where it's both. Look at the pancreatic, in the middle of the image, in the center of the image, a hot lesion. But it's both FDG and dotatate because it's the grade 2. And then the top right is the grade 3. It flips. It becomes FDG avid, non-dotatate avid because it's the grade 3. I'll give you other examples. Here. This is the patient. These 2 scans are a month apart. Well-differentiated grade 1 neuroendocrine tumor. In the beginning, when we started doing dotatate and we get an FDG, I really was sometimes calling the tech and say, are we sure this is the same patient? Are you sure you didn't mistakenly like label the patient wrong? Because look at these two scans. Do you believe these are done a month apart and it's the same patient? It's fascinating, the difference. In the early time when I started doing this, it was like I had to double check and make sure that I'm doing the same patient. Because it's scary. The FDG was totally negative, and the dotatate is studded with metastatic disease, studded. But it is true, it's the biology. This is grade 1, well-differentiated metastatic neuroendocrine tumor. It's non-FDG avid whatsoever. This is why when we discuss in our tumor board, and we have neuroendocrine tumor board twice a month, if you give me images, I can tell you the pathology. And sometimes when we have an outside, most of the time it's going to be an outside read that wasn't read in ours, I would say, no, I would not agree with the outside read and say, no, this is not true. The imaging doesn't say this. The image behavior doesn't agree with this pathology. I think we need to reread this these slides, because the imaging is saying this is a grade 1, or this looks like a grade 3 or whatever, right? Now, this is another one. Let me show another one. Come on. Yeah, this is a grade 2. Because once it takes both FDG and dotatate, this becomes in the grade 2 area, right? This is a grade 3. See, it flips. How do you know it's FDG? Because there is brain uptake. Once there is a brain uptake, this is an FDG. This is the clue. This is my trick. Yeah. Okay. All right. I'm gonna go quickly because we're finishing. We should be finishing, and there's a lot of slides there. It's not doing it. Okay. Oh, PRRT I think was the other one. So I'll talk a little bit about theranostics quickly. Theranostics is a new term, not a new field. It's a new term. Somebody thought about, this is something we've been doing in nuclear medicine for more than 80 years, because radioactive iodine for thyroid cancer is theranostics. So we've been doing this forever. But theranostics, what's theranostics? Somebody smart thought about this fancy term. So they took a piece of therapy word and the piece of diagnostics, and they stuck them together. It became theranostics. That's it, all right? Why is it? So what our radiopharmaceutical is what? I told you. A biological part that binds to a receptor, and then we attach it to a radioactive part that we can see or we treat with, okay? So what we do is we have a biological part, the same biological target, we hook it once with a diagnostic radioactive part, and then the next time we hook it with a therapeutic. So it's the same target. So we can image the patient first, see where is the disease, and then we treat knowing what are we treating before we treat. Usually you treat and then image, and then know what did you treat. No, we know what we're treating before we treat. This is the cool part of it, right? Okay, so neuroendocrine tumor have somatostatin receptors. We inject the dotatate, image, see where is the receptor distribution, then in a different day, we treat with lutetium-177 dotatate, knowing exactly where is it going, because we already have a map of the somatostatin receptors, right? So this is the theranostics. Okay, I'm going to skip all that. You guys know about the knitter. I'm sure we talked about this so many times. So what is the regimen? What do you guys do? You have to stop the long-acting, of course, somatostatin analog, because there is a competition with it 4 weeks prior. We do 4 doses. This is the standard. Each one is 200 millicurie, right? You come to around 2 months apart. So think of it like 8 weeks apart, right? Of course, there are a lot of things in the middle. We can modify the dose based on your labs. If you find the labs are a little bit dipping down and it's not picking up, we can do one of 2 things. Either delay the 8 weeks a little bit more. We can just wait a little bit for your marrow to, because it should pick up. The labs should come back up, right? So we can wait a little bit more, or we can decrease the next dose a little bit and see if this doesn't hit it as high, right? Now, when the day of, what happens? You come, we start with antiemetics, and then what? We start the amino acids, right? And then what? 30 minutes after the start of the amino acid, we start the Lutathera, while the amino acid is still going on. So both of them are coming in. And then after we finish our Lutathera, 3 hours of amino acids. So we have to do 3 hours of amino acids after the finish of Lutathera. So if we started Lutathera later, we have to still do 3 hours after the Lutathera, right? And these are the amino acids. I don't think you care about it. We give, this is an outpatient treatment, or our radiopharmaceutical or outpatient treatment. So you are gonna be going home after you get it. You're not gonna be admitted to the hospital. In our institutions, we give release instructions. What does that mean? You're not going to be harmful. You're not going to hurt anyone from your beloved one. And this is so important to know. I care to say this to all the patients I treat, not only neuroendocrine tumor. You're not hurting any of your beloved ones because you are radioactive. But it's unnecessary for them to get any radiation from a treatment you're getting. You're getting benefit from that treatment, so you're getting some radiation from it. Your relatives or friends, it's unnecessary for them to get radiation because they're not getting any benefit. So if you follow these very simple instructions for these very few days, you're just preventing them from getting any kind of radiation from your treatment. That's it. So you're socializing with them, right? I'm not saying you just have to lock yourself in your room. Nonsense. You should not isolate yourself. Nonsense. You're not contact. You're not harming anyone. You're not going to glow in the dark. I'm sorry. I'm not going to promise you that you're glowing in the dark. It's not going to happen. I'm sorry. You're not. You can have dinner with your family. You can sit and watch TV with your family just 3 feet away. Come on, guys. COVID-19 was 6 feet away. COVID-19 was even more than us. Can you believe it? When COVID-19 came in, I said, oh, my God, that's amazing. So I can tell them, even if you follow the COVID-19 precautions, this is even better than radiation precautions. It is. We ask for 3 feet. They ask for 6 feet, right? Just 3 feet. So they can be at one end of the couch, and you are at the other end of the couch. Can you believe it? 3 feet, just an arm length from anyone. You can even hug your beloved ones. So distance, time, right? Don't be sitting very close for a prolonged time. But short hugs are okay, right? Talking a little bit, okay. But don't sit for 2 hours hugging your husband or your daughter for 2 hours. No. Or put somebody on your lap for 2 hours watching TV. No. So time and distance. This is what you have to be careful with. But you're not hurting anyone. Don't be miserable because you got a radioactive treatment. Nonsense. You're not hurting anyone. This is so important to emphasize. If you come out of this session with this, I am so happy, I will go home happy. If you got out of this with this message, you're not hurting anyone. Please don't. The radiation is overrated in the media. Yes, you don't want to get radiation, but come on. We get radiation. If you take a flight to California, you're getting a lot of radiation, by the way. People don't know that. Okay, I'm not saying we should get radiation. I'm not saying that. But we should put everything in context. Don't get everything out of context. This is all I'm saying. All right? Come on. Yeah. This is just an example. A patient who had metastatic bronchial cancer, neuroendocrine tumor, I'm sorry, and then, came a year later with progression, and then we decided to do PRRT. And we image 5 days after each time we do because it actually emits gamma as well, not only beta. So we image 5 days after, and these are the imaging after each one, and there are decreases. And the most important thing is the quality of life is improved after the PRRT. Because we do treat patients with advanced disease, so they're not going to totally clear, but they improve. Future direction, there's a lot of research going on right now. A lot of things trying. So they try to enhance the treatment. There's a lot of research about antagonist, not agonist. What we're doing is agonist. Now we're trying antagonist. It improves the uptake. There's a lot of research about alpha versus beta. There's a lot of research about intraarterial, intravenous. And we are combining the PRRT with other radiosensitizers. We are involved in a lot of the research with this, right? And this is, I'm going to have to flip because I think my time is up. Alpha is bigger. The beta is small, tiny, like a particle, electron, right? The alpha is 2 proton, 2 neutron together. It's like a helium particle. It's big. So it causes a lot of harm. Can you imagine like hitting like a tennis ball, hitting a cannonball, right? You do a lot of harm, but then it's heavy, so it doesn't travel a lot. See how much it travels? It doesn't travel a lot. So it doesn't cause it causes less side effects. So there's a lot of research with alpha, radio labeling with alpha particles now, not beta. The ones that we have available is beta. Now we have alpha, right? In the research. There's new radiopharmaceutical now, right? One of them is actually for the higher grade neuroendocrine, not only the low grade neuroendocrine tumor. So really, during the last 3 decades, there has been significant advances in the imaging and therapies, and we are in a really good time right now for all these theranostics. Combining the diagnostics and the therapeutic is amazing, and definitely, you guys know, we are part of the we are basic part of the workup and the management of neuroendocrine tumor. And I talked to you about the multiple new approaches, and there's a lot. I even cannot keep up with all the advances. Every time I look up, there's something new that, oh my God, oh, whew, this is the new things. I cannot keep up with in my specialty even. And I try to keep up because I should. Thank you so much for your patience.